Hi, welcome back to the Modern Orthopaedics podcast. My name is Shannon. I'm the Director of Marketing here at Orthopedic Specialists of Dallas. And I've got Dr. Nilpesh Patel here today, and he's going to talk a little bit about himself and what he does here.
Good morning. So I'm originally from North Carolina, and I have been practicing orthopedics for about 10 years here in the Dallas-Fort Worth area. I joined Orthopedic Specialists of Dallas about 2 years ago, and I specialize primarily in the hand, wrist, and elbow. I did initially start my career doing general orthopedics and a little bit of everything, and have kind of taken a focus on the hand, wrist, and elbow as you know, this is interest of mine and something that I did more training in.
All right. Where did you go to medical school, Dr. Patel?
I went to the University of North Carolina. I was there for undergrad and medical school, so I bleed Carolina blue.
Okay.
I then went to Emory to do my residency, and then across the country to Seattle for fellowship in hand, wrist, elbow.
And why did you decide to become a physician?
You know, that's an interesting question. I don't have a big one glorious moment that told me I needed to become a doctor. You know, I kind of grew up in a very business-oriented family in a small town in North Carolina, about 10,000 people. You know, when I went to college, I actually was a big interest in political science, and I actually have a political science degree. And what's interesting about it is, you know, I went from election politics to healthcare policy and politics, but a lot of the classes that were there at University of North Carolina were really service learning and service-based courses. And that, in a mix of me starting to understand by taking those classes that I was probably more of a science math guy, but really loved the helping people service aspect of both learning myself and doing the actual activities, really kind of start giving me the drive to, hey, you know, just that natural feeling of I wanted to help people. You know, I learned that maybe politics wasn't the thing for me. The policies, even, you know, election politics, as we all know, is crazy these days. And, you know, even back then, you know, it was an interesting field while doing internships and stuff that kind of was challenging and made me think, okay, this is the bureaucracy and stuff I didn't want to really get into. And so I think, you know, a combination of me starting to understand that, hey, these are the things that drove me, that I'd like to see in the community, you know, us getting people healthier, and how this not only helps, you know, everyone as a society, but also kind of gives me the drive to keep doing things more and more. I mean, I think it really drove me to be a doctor. So
awesome. And what made you choose your specialty of hand, wrist, elbow? When did you decide that? So,
you know, I did residency in orthopedics. Our orthopedic residency was very heavy trauma driven. So that means injuries that happen because of accidents. We also had a big spine influence in our residency. A lot of this is probably because, you know, I was in Atlanta, inner city, and it was really the only level 1 trauma center in all of Georgia at that time. So a lot of stuff was driven, you know, by that. And so there wasn't as much training in the hand, wrist, and elbow. So, you know, when I got out, I knew that, hey, I wanted to probably live in an area that's more urban, you know, or on the outskirts of that. And I think the way orthopedics was going, you know, that's something I wanted to specialize in one particular thing and be good at that. And the thing that I had the least education in, that I had the most interest in, really was hand, wrist, and elbow. And the things that I did pick up is, hey, you know, you could help people very quickly with surgery that seemed very simple. And what I mean by that is, hey, I can take some suture, which is like thread, and fix a tendon, and bada boom, I don't have to put big implants in. And these people can go out and start, you know, theoretically moving their hands in a controlled way and slowly get back to activity. And so it was almost the simplicity of it, but the complexity of, you know, all the other parts that I didn't know that drove me to become kind of a hand surgeon.
So the patient outcomes are usually pretty good in your
you know, I think Yes, there is always, patient outcomes is always something that we kind of look to. I mean, in all of orthopedics, and I think, that is also the wave of the future. Looking at how patients do, and that's not just from studies and animal models and biomechanics. It's really, okay, are patients satisfied? Do they feel better? Is their pain better? And you're now seeing that in general in orthopedics as, hey, we're doing these surveys from both a physician standpoint as well as big systems and hospitals are doing this to try to figure out, okay, are we really treating the patient in the right way? Or are we just doing this for science? And I think, in hand surgery, generally patients improve. I think like all of orthopedics, all of medicine, the biggest thing is educating the patients on what to expect. Right. And that means that when someone comes in and talks to me about, hey, I want to have this surgery, or I'm thinking about this, I have carpal tunnel, I have an elbow problem, then you have to tell them, okay, well, if we did this, these are the things that could improve and that you need to expect to improve, but this may not improve. And, I think that has a lot to do with the way you actually kind of define outcomes, not just saying, okay, this surgery is just going to make you 30 years younger. That's not how it works.
Okay. And will you go into some of the complex procedures that you do with the hand, wrist, and elbow?
Yeah. So, I started this by thinking of a patient, that I've done. And I think, one of the first early patients in my career was this lady who fell and just destroyed her elbow. I remember being called on Friday evening. I was out to dinner with my wife and I was like, okay, I got to do it tomorrow. And, I went in there thinking 3-4 hours and ended up being like 6 to 8 hours of surgery. And when I went into this elbow, my initial thought was there's no way I can fix this. This needs a replacement. But I ended up fixing it. The x-rays were things that even the people in the rooms took pictures of because of, it was just crazy, the amount of fixation needed. And it was a complex case but she ended up doing awesome. And when she came to the office, I was like, she's going to end up with a stiff elbow. She's not going to do well. And then she comes in and she's like, oh, this feels great. 6 months later, back to everything. That kind of, the elbow is something that, in terms of reconstruction, injuries that are acute, and by that I mean fractures and dislocations of the elbow. Those are things that are, to me, complex. For me, I think those surgeries challenge me. They also have outcomes which, there's going to be people that end up with stiff elbows. The injury is really complex, but then when you see, hey, this lady that can move her elbow, has good pain relief, able to get back to activity. It's really satisfying. And it gets people back to activity. And that's the key here. But for me, things that I've seen, also revision surgeries in the hand, wrist, reconstructions, those things are the complex things. You don't know what you're going to get into if you're going in and revising surgeries that other people have done. Most recently, I do total elbow replacements. And revision of total elbow replacements. And, there's a guy that's had, I think, 3 revisions. And then I went in there and, had no idea what to expect. And, basically we were doing this huge revision on this elbow where you're cutting out a significant amount of bone and replacing it with metal. And then they come back to their first visit and they're like, man, I feel great. Pain's better. And, you look at your x-rays and you're like, your whole arm's metal. How is this possible? But, they feel better. And, it's a big surgery. It's a complicated surgery. I think things around the elbow for me are a challenge. I think it's a good mix of bone and soft tissue, and understanding the anatomy. I think for me, I would say, hey, if I had to pick the most difficult things I do, the things that are challenging, that's what I'd say.
What about Tommy John surgeries? I think that's something that a lot of people don't know that we do here. Yeah. So if you'd like to go into that a little bit, I think that.
Right. So, Tommy John surgery has been out in the media a lot. Okay. And the people use the word Tommy John, and Tommy John, is a procedure. And people say that without sometimes understanding the injury, right? So the injury is actually an ulnar collateral ligament injury of the elbow, right? And it's important to understand that these things can happen from a overuse type of situation, as we see in pitchers, or certain mechanics that are affecting that, as well as traumatically. Okay. I mean, and we can see the same type of ligament injuries in both these fashions, though there is some difference in each of those. And I think, people need to understand that, because I'll have people that have an acute injury. That means that they fall, they land on this, and then, they're like, I need a Tommy John surgery. Well, maybe it's not a Tommy John surgery because the procedure is different, though the injury is similar. Okay. And what that means is, as our community is focusing on certain sports, we see athletes that are, doing year-round baseball. We have to focus on making sure that they know the proper mechanics, that they're doing full body training, that, hey, they're maybe spending some time doing training of the other parts of their body. And at the end of the day, the Tommy John surgery is to correct an ulnar collateral ligament issue, which gives the feeling of instability and pain in throwing athletes. Okay. And in that throwing motion, because of that, people will get pain on the inside part of their elbow. They'll have difficulty throwing, difficulty producing the force needed, the speed needed, or able to do the types of pitches that they want to throw. The big part about Tommy John surgery is not just the surgery, because, hey, we know that there's things changing every day on how we do this surgery. We moved from reconstruction using tendons from the same arm and moving them to this area. Now we can still use tendons, and we can even back it up with, we call it internal bracing, which is, hey, this fiber type tape, which kind of helps hold this construct more stable and allows us to do some activity faster or get it back to rehab faster. And so things are changing, and it's the rehab part, the after surgery part, which is what's important to kind of dig into the athletes, making sure the parents understand, making sure the athletes understand that, hey, it's going to be a big commitment for this time period. And then, making sure that the patient actually needs a surgery, so we go through a period of, rest, the appropriate rehab, the appropriate core strengthening, making sure the rest of the body is good. During that whole period that these athletes are resting, they still need to be working on their technique and their biomechanics. And once all that is good, and if they go back out there in a controlled fashion and, hey, this is still an issue, then, we start thinking more the surgical route. And then, hey, how we're going to approach this? Is it going to be the 6 months to a year recovery? It's going to be a program of motion, then strengthening, then throwing the pitches, getting them back to the distance they need to be, and then, hey, to the force that they need to put on it.
So stem cells becoming very popular now. What do you think about that with what you do, sir?
So, it's interesting, the whole kind of era of stem cells. So, I think first it's important to understand what that means, right? So you're taking a cell that has not been differentiated. And what does that mean? That means that you take a cell that can kind of maybe slowly become something else, and you're putting that into your body. Okay. And a lot of this has been done initially in cancer or rheumatoid type patients. Hey, do we put this into the blood and they differentiate and then help cure things? In orthopedics, we don't quite know that yet. Okay. So we don't know, hey, if we put this into a joint, is this really curing things? And I think you also have to take that from a context of, does that mean that it's not working? Does that mean it's not something we should do? No, that's not necessarily that, because a lot of what we do in orthopedics is for pain relief, for function, getting back to activity. It's not because I can give this patient new cartilage, right? And so, I think we have to take one step back and understand what stem cells are, what they're meant to do, and in that field of medicine, how it's really going to help us and help the patient. At the end of the day, it's helping the patient. So, I think in orthopedics, in upper extremity, I think there is going to be at some point even more information out there with research and the science behind it. And as we are improving every day, okay, is this really going to cure something? Is it really going to regenerate something by just simply injecting it into the body? Or is it going to need something else that's going to help us do this outside of the body and then inject it, right? Is it more of a soft tissue healing product? Is it, hey, tennis elbow? Is it going to heal that completely? Is it going to take these Tommy John injuries and really heal the Tommy John injury completely? And I think though we have some inkling into where this is going, I don't think there's a definitive answer to that yet. I think from a pain generation standpoint, there is some evidence that it's helping, but a lot of injections help. Right? You could give a steroid injection and they help for pain. And so we got to differentiate, okay, is this really better? Right? And some of that also becomes very patient specific. Hey, we go through these steps with the patients. We decide, okay, is this working, this not working? Hey, let's do stem cells. And does this give you the pain relief? So I think the idea of just complete regeneration, I think we got to take a step back and hey, yes, there is potential for this. Are we there 100% yet? Probably not.
Can you explain the difference between stem cell and PRP, and do you do these in the office?
So number one, we do these in the office. Okay, that's a simple answer. PRP is taking your blood and we spin it down. We take portions of that, which are plasma-rich protein, and we inject it back in to get healing factors into the area. Okay. And in my world, doing that a lot in soft tissues, tennis elbows, biceps type injuries, even in wrist, tendonitis, tenosynovitis, things that are torn. We can do those things. Stem cells comes in kind of variations. You can get, almost off the shelf stem cells that you're injecting back. You can also get stem cells from certain areas of your own body and put them back and get these cells that, like we'd explained, hey, you're trying to get them to differentiate into another type of cell to do some sort of restoration or healing.
All right. So besides the stem cell and PRP, are there any other procedures that you would do in office?
That's a great question. So, we are moving to a world of trying to help patients, get them back to activity faster, get them out of the office, out of the surgery suites and home. Okay. And a big push has been doing things in the office, and that includes surgical procedures. So from a hand standpoint, there are many surgeries that, hey, we think and we know that we can do under what we call local anesthetic, which means, hey, you inject numbing medicine, they feel numb, the patient is completely awake. There is no other medicines given in terms of pills or IVs. You do the procedure, the patient gets instructions, they understand, they know everything going on, they see it with their own eyes, they walk out of the office and go home and start, hey, working on the after surgery rehab very quickly. And this is a big thing that we're pushing. I think I'm moving to doing a lot of my procedures, obviously with some insight into which ones really patients will benefit best from doing in the office, as opposed to moving everything to surgery centers and to surgery suites. I think initially things like carpal tunnel, trigger fingers, some certain cysts in the hands, those type of procedures are going to be very beneficial to do in the office. They benefit the patient from multiple standpoints of doing it awake. There are procedures that, hey, patients can get back to activity very quickly. And why go to sleep? Why do they need to be knocked out, spend half their day or all their day recovering from something that really they can walk away from?
And paying for anesthesiology fees and
right. So yeah, and that's a big, big point. So from a cost standpoint, bringing things in the office are cost beneficial. And from a global standpoint, they reduce the cost of healthcare. And I think that's what, we need to look at is, hey, how are we still doing the patient outcomes, patient satisfaction, making sure the patients are still doing well, but we're reducing the global cost of healthcare. And, by moving these things in the office, that's going to happen. The cost for the insurance companies, the cost to the patients directly, the cost of patients being off work for a whole day or two and not, getting anesthesia, the cost associated with all of that is going to decrease. And, quite frankly, that's the way we should all move for doing things.
Dr. Patel, can you give us any examples of any complex hand and wrist procedures that you do?
Of course. So, you hear about the day-to-day things of hands and wrist, carpal tunnel, trigger fingers, things that you see in the news all the time. But some of the bigger things we do is really dealing with arthritis and also trauma type injuries. People don't hear or think about arthritis in the hands and wrist, but it exists. It's actually very common and very debilitating for patients. And we do procedures that do include joint replacement, and that is in the wrist joint itself. Though we are very selective on these patients and, based on what activity they're trying to get to. I remember, for example, that there was a patient that, he was actually quite younger in the, I think, 50s and 60s, and that's young for us in terms of doing joint replacements. But he had a condition where he had a wrist which was very arthritic because of other medical issues, and specifically he wanted to just get back into doing his day-to-day life, taking care of himself. He had some kids he wanted to hang out with, do certain activities with. It wasn't a high impact type of activities, but it was just his day-to-day life living. And, after talking to him, I think he was a good patient for a wrist replacement. Went in, did a wrist replacement, which really means just like the knees and the hips that you hear about all the time. We take a certain portion of the cartilage and bone out. We replace it with almost like a metal and plastic combination. And they're allowed to start moving very quickly and slowly advance into good use. And it was a great pain relief and functional benefit for this patient. In the hands, there are multiple procedures for arthritis that include things where we take bones out, reconstruct joints, and patients do very well from that. And so, I think from a complexity standpoint, all these surgeries can be very complex, depending on, the patient. We tailor everything towards, is what will benefit the patient in terms of getting back to activity and function the fastest and the best, and where they're going to benefit from their pain. A lot of this is, I'm hurting and I need to figure out if I address this joint, is my pain relief going to be 80%, 70%? And then we tailor the surgery. As you know, the hands and wrists are very complex in terms of there's a lot of joints, a lot of bones that actually move the wrist and the hand. So that's the important part of examining the patient, understanding what activities they're doing, and then figuring out what procedures to do from that standpoint.
It sounds like a lot of your procedures that you do require a lot of therapy and a specific type of therapy.
Yeah. So, occupational therapy is important after surgery, especially in the hands and wrist. We have occupational therapists that actually specialized in doing the hands. And we will create a whole program of rehab after your surgery or even before your surgery to work with these occupational therapists in getting back to movement and strength. A big part of hands is getting the motion of the hands back. Stiffness is a big issue and a big challenge. And so we kind of gear things that we want to get things moving fast, but in the right way. And so it's always good to have the guidance of an occupational therapist to help do this in the right way so that you're protecting the things that need to be protected before and after surgery. And then, not just the things that you can do as a patient, but then how to advance and how to get to the point where, hey, I can start my strengthening, I can start throwing things, I can start working on weight training, all of those. And so, in-house occupational therapy here at Orthopedic Specialists of Dallas is an important part of our whole program in the hand, wrist, elbow. And, it's something that we keep continuing to grow and educate the community on.
Well, thank you very much for your time today, Dr. Patel.
Thank you.